In this video, we will cover myocarditis. Myocarditis is a focal or diffuse inflammation of the heart muscle called the myocardium. This inflammation can happen in one area or it can spread out. This inflammation weakens the heart muscle, making it harder for the heart to pump blood. When the heart muscle is inflamed, it can affect the heart's electrical system. This can cause arrhythmia or a rapid or abnormal heartbeat. Myocarditis can cause the heart muscle to weaken and it can lead to cardiomyopathy. Myocarditis can be caused by viral infections or more systemic inflammatory conditions such as autoimmune disorders. Sometimes myocarditis is caused by a medicine reaction or a condition that causes inflammation throughout the body. The inflammation can also cause other changes to the heart muscle cells that may be acute or chronic. Myocarditis can affect small or large section of the heart muscle, making it harder for the heart to pump blood. Myocarditis can cause chest pain, shortness of breath, and rapid or irregular heartbeats. Clots can form in the heart, leading to a stroke or heart attack. This rare condition can affect people quickly or slowly over time. Myocarditis can lead to other serious heart conditions such as heart failure, cardiomyopathy, and arrhythmia. Inflammation can extend to the pericardium and cause a condition called myopericarditis. This will cause symptoms of both myocarditis and pericarditis. Myocarditis is different from other types of inflammation because each kind happens in a different part of the heart. Pericarditis affects the sac around the heart. Endocarditis is an inflammation of the inner layer of the heart. It involves the heart valves. There are different types of myocarditis. They include acute myocarditis. Acute myocarditis describes relatively recent or fast onset of myocarditis and is usually caused by a viral infection. Acute myocarditis can develop suddenly and symptoms may resolve rapidly as well. Chronic myocarditis. Chronic myocarditis is when it takes longer than usual to treat the disease or when symptoms reappear after experiencing the condition. Chronic myocarditis is typically caused by another medical condition like an autoimmune disorder in which the immune system attacks healthy cells and tissues in the body. Next type is lymphocytic myocarditis. Lymphocytic myocarditis is a rare form of myocarditis that can result in hospitalization for acute care. It occurs when white blood cells, that is lymphocytes, enter and cause inflammation of the heart muscle. This condition can occur after a viral infection. Next type is eosinophilic myocarditis. In this type, the cardiac tissue is infiltrated by another type of pro-inflammatory blood cells, that is eosinophil. Eosinophilic myocarditis is further distinguished from non-eosinophilic myocarditis by having a different set of causes and recommended treatments. Other rare types of myocarditis include giant cell myocarditis. This type of myocarditis is a very rare type of heart muscle inflammation. Inflammatory cells come together to form giant cells that attack the heart muscle and cause scarring. This can quickly lead to problems with how well the heart can pump blood, contract all of its parts at the same time during a heartbeat, and how well the heart can allow heartbeat signals to take a normal, uninterrupted route through the heart. Next type is fulminant myocarditis. Fulminant myocarditis is characterized by a rapid progressive decline in cardiac function and a high mortality rate. Fulminant myocarditis is an inflammatory process that occurs in the myocardium and causes acute onset heart failure. Causes of myocarditis. Myocarditis is a rare focal or diffuse inflammation of the myocardium. It may be acute or chronic. Sometimes the cause of myocarditis is unknown. But when it occurs, it is most commonly caused by an infection in the body or other factors unrelated to infection. Infections from viruses, bacteria, fungus, or parasites can lead to myocardial inflammation. According to the causes, it can be divided into infective myocarditis and non-infective myocarditis. The infective myocarditis is caused by infections from viruses, bacteria, fungi, or parasites. Non-infective myocarditis is caused by factors that are not infections. Some non-infective causes include medicines, autoimmune conditions, other medical conditions such as giant cell myocarditis, and some cancer treatments such as immune checkpoint inhibitors or radiation. Autoimmune diseases such as lupus, sarcoidosis, and others can also cause myocarditis because the immune system can attack any organ in the body, including the heart, causing inflammation. Drugs or other environmental or toxic exposures can lead to myocarditis as well. Many viruses have been linked to myocarditis, including the adenovirus, which causes the common cold, the COVID-19 virus, viruses that cause hepatitis B and C, parvovirus, which causes a mild rash, usually in children, herpes virus 6, Coxsackie virus A and B virus are the most common causative agents. Gastrointestinal infections due to echoviruses, Epstein-Barr viruses which cause mononucleosis, and German measles, also called rubella, all can cause myocarditis. Myocarditis also can be caused by human immunodeficiency viruses, the viruses that causes AIDS. Myocarditis may develop after influenza A or B. Cytomegaloviruses, adenoviruses also can cause myocarditis. Bacteria can cause myocarditis include Staphylococcus, Streptococcus, and bacteria that cause diphtheria and Lyme diseases. Parasites that can cause myocarditis are Trypanosoma cruzi and Toxoplasma. Some parasites are transmitted by insects and can cause a condition called Chagas disease. Chagas disease is much more common in Central and South America than in the United States. A fungal infection may cause myocarditis, particularly in people with weakened immune systems, which include yeast infections such as Candida, molds such as Aspergillus, and Histoplasma. Myocarditis also may be caused by radiation exposure. Exposure to radiation can sometimes cause myocarditis. Most cases are the result of therapy for Hodgkin's lymphoma or breast or lung cancer. Less common are exposure to a nuclear reactor or after detonation of a nuclear devices. Myocarditis may be associated with exposure to certain chemicals called arsenic and hydrocarbons. Myocarditis can be caused by insect bite, snake bite. Exposure to carbon monoxide can sometimes cause myocarditis. Other health conditions like lupus, vagus granulomatosis, giant cell arteritis, and Takeusa's arthritis can cause myocarditis. Certain medicines or illegal drugs can cause myocarditis. It may be associated with chemotherapy, immunosuppressive therapy, or vaccinia inoculation for protection against smallpox infection. Allergic or toxic reactions to antibiotics such as penicillin and sulfonamide drugs. Some medications for the heart, antidepressants such as benzodiazepines, some psychiatric drugs, medicines for seizures, medicines for weight loss, diuretics, cocaine, these can cause myocarditis. When these cause myocarditis, it is called drug-induced myocarditis. Who are at the risk of myocarditis? Some of the things that put client at risk for myocarditis can be changed. Clients are more likely to get myocarditis if client is a young adult. Client is male, but females can get it too. Client's body doesn't react well to inflammation. Although clients don't inherit myocarditis, the genes influence how the body handles inflammation and how likely client is to get myocarditis. Clients who drink alcohol more than the limit, these people are at risk of getting myocarditis. Some medical treatment increase the risk of myocarditis include dialysis, implanted heart devices, radiation, treatment for heart problems having a central venous line. Some medical problem can put client at a risk of getting myocarditis include systemic disorders such as sarcoidosis, celiac disease, autoimmune conditions such as systemic lupus and other collagen diseases may cause myocarditis. Diabetes, HIV or AIDS, skin injuries or infections, eating disorders, end-stage kidney diseases, a chest injury can also cause myocarditis. Now we will see the pathophysiology of myocarditis. Although not completely explained, the pathophysiology of acute myocarditis has been divided into three phases. The first stage is viral phase. It has been believed that acute myocarditis is initiated by either a reactivation of a dormant virus or an introduction of a new cardiotropic virus, that is Coxsackie virus, in the host myocardium. This phase is usually short. Cardiotropic viruses enter to cardiac muscle cells usually via binding to a transmembrane receptor. Over approximately the next 1 to 7 days, the virus replicates and causes inflammation leading to necrosis and apoptosis of cardiac muscle cells and activation of the innate immune system. The innate immune system works to fight against pathogens. Over the next 1 to 4 weeks, viral replication continues with subsequent activation of the acute immune system leading to T-cell infiltration and the formation of antibodies, including possibly autoantibody. Over the next few months to years, this process either resolves and concludes with viral clearance, or it may progress to cause permanent heart damage such as dilated cardiomyopathy, ventricular dysfunction, or other cardiomyopathies. Data from endomyocardial biopsy from patients with acute myocarditis and fulminant myocarditis show a high prevalence of parvovirus B90, although its pathogenic role is still discussed. Nowadays, it is believed that common respiratory viruses like influenza viruses, rhinoviruses, and coronaviruses can trigger acute myocarditis through an immune-mediated lymphocytic myocarditis. Next stage is immune activation. Although viral replication within the myocardium can be injurious to itself, most of the tissue damage results from an unregulated host immune response in an attempt to eliminate the infected cells. This phase is characterized by the activation of virus-specific T lymphocytes. T cells clonally expand to neutralize the original antigen, which could be a myocardial protein instead, leading to greater myocardial destruction by molecular mimicry. Molecular mimicry is one of the leading mechanisms by which infectious or chemical agents may induce autoimmunity. Interleukin 6 is thought to play a key role in this inflammatory cascade, with subsequent activation of B lymphocytes and production of antibodies. This phase usually lasts for days or weeks, even if in most cases resolve spontaneously. An alternative explanation is that in virus-triggered acute myocarditis, there is a molecular mimicry between viral and cardiac antigens that might result in autoreactive T-cell infiltration in the myocardium in predisposed individuals without the need for viral infiltration of the heart. The binding of many types of coronavirus through ACE2 receptors present in heart muscle may be responsible for direct viral injury leading to myocarditis. It was also observed that an already diseased heart has increased expression of ACE2 receptor contrasted to healthy individuals, which may lead to greater viral infiltration in the heart muscle. Hyperactive immune responses in COVID-19 patients may lead to the initiation of the cytokine storm. This excessive release of cytokines may lead to myocardial injury. In addition to direct cardiac myocyte damage due to severe acute respiratory syndrome coronavirus 2, viral infiltration and inflammation, there are other suspected mechanisms that COVID-19 may indirectly cause myocarditis. During COVID-19, the other indirect mechanisms thought to contribute to myocarditis include oxygen supply demand mismatch to the heart muscle leading to myocardial injury, microvascular thrombi, or blood clots in the small blood vessels of the heart causing injury, the systemic hyperinflammatory state in COVID-19 leading to heart muscle injury, or the virus causing indirect damage to the heart by inducing autoimmune mediated damage to the heart muscle. Next stage is myopathy phase. In most cases of acute myocarditis, the immune response is properly modulated and adaptive, with the eventual elimination of viral replication when present, allowing the myocardium to heal without sequelae. However, in some cases, the infection is not well controlled and the inflammation persists. When the myocardium becomes infected, the causative agent invades the myocytes and causes cellular damage, leading to myocardial necrosis, ventricular remodeling, and dilated cardiomyopathy. This activates the immune response. Cytokines and oxygen-free radicals are released. The persistent release of cytokines activates metalloproteinase, which cleave and digest the extracellular framework of the myocardium. Eventually, myocardial fibrosis may develop, sharing common molecular pathways with other cardiomyopathies. As the infection progresses, an autoimmune response is activated. This causes further destruction of myocytes and the heart dysfunction. It may begin in one small area and then spread throughout the myocardium. The degree of myocardial involvement determines the degree of hemodynamic effect and resulting signs and symptoms. It is theorized that dilated cardiomyopathy is a latent manifestation of myocarditis. What are the signs and symptoms of myocarditis? In the early stages of myocarditis, client may have few or no symptoms at all. Symptoms can be very different from person to person depending on the cause of myocarditis. The features of myocarditis vary from a benign cause without overt symptoms to progressive heart failure, dysarrhythmias, or sudden cardiac death. Fever, fatigue, malaise, myalgias, pharyngitis, dyspnea, lymphadenopathy, and nausea and vomiting are early manifestations of the viral illness. Early cardiac signs appear 7 to 10 days after viral infection. Pericarditis often accompanies myocarditis. Signs include pleuritic chest pain with pericardial friction rub and effusion. Late signs relate to the development of heart failure and include an S3 heart sound, crackles, jugular vein distension, syncope, peripheral edema, and angina. Symptoms depend on type of infection, degree of myocardial damage, capacity of myocardium to recover, and host resistance. It can be acute or chronic and it can occur at any age. Symptoms may be minor and go unnoticed. Common symptoms may include rapid or irregular heartbeats called arrhythmias, fatigue, shortness of breath, that is dyspnea at rest or during activity, lightheadedness, occasional precordial discomfort or vague chest pain, heart palpitations, pain in the abdomen. Patient may not have appetite, swollen legs or feet, exercise intolerance, cardiac enlargement, abnormal heart sounds, murmur, S3 or F4, or friction rubs. Signs of heart failure like pulses alternance. Pulses alternance is a physical finding with arterial pulse waveform showing alternative strong and weak beats. Other signs of heart failure such as dyspnea, crackles, lower extremity edema, and low urine output. Patient may have fever with tachycardia or other sign of viral infection such as headache, body ache, joint pain, and sore throat. Sometimes myocarditis symptoms are like symptoms of a heart attack. If client is having unexplained chest pain and shortness of breath, seek emergency medical help immediately. When children get myocarditis, symptoms may include difficulty breathing, rapid breathing, chest pain, rapid or irregular heartbeats called arrhythmias, fainting, fever. Myocarditis symptoms will depend on the level of inflammation and whether the pericardium is affected, that is called myopericarditis. Myocarditis can lead to heart failure, rhythm disturbances, or rarely cardiogenic shock. Often, there are no physical signs of myocarditis. Myocarditis can be difficult to diagnose due to non-specific symptoms and signs. The doctor will ask for a thorough review of the medical history and symptoms and may perform the following tests and procedures. Blood tests are usually done to check for a heart attack, inflammation, and infection. A cardiac enzyme test can check for proteins related to heart muscle damage. Elevated antibody titers, that is ASO titer, is done to check for infection linked to myocarditis. Laboratory findings are often inconclusive. They may include mild to moderate leukocytosis and atypical lymphocytes, high viral titers, and increased ESR, CRP levels, and levels of cardiac biomarkers such as CPK and troponin may be elevated. elevated WBC count and sedimentation rate, stool and throat cultures isolating bacteria or a virus. Electrocardiogram shows how the heart is beating and if currently has irregular heartbeats. The ECG changes with myocarditis are often non-specific but reflect pericardial involvement. For example, diffuse ST segment changes. Dysarrhythmias and conduction problems may be present. Transient ECG changes, ST segment flattened, T-wave invasion, conduction defects, extrasystole, supraventricular and ventricular ectopic beats can be seen. Chest X-ray shows the size and shape of the heart and lungs. A chest X-ray can tell if there is a fluid in or around the heart that might be related to heart failure. Chest X-ray may show heart enlargement and lung congestion. Heart MRI or cardiac MRI test uses magnetic fields and radio waves to create detailed images of the heart. A cardiac MRI shows the heart size, shape, and structure. It can help diagnose myocarditis. Positron emission tomography scan can be done to diagnose myocarditis. Nuclear imaging using gallium or yttrium helps detect myocardial inflammation. An echocardiogram can show the heart size and how well blood flows through the heart and heart valves. An echocardiogram can see if there is fluid around the heart. Cardiac catheterization and heart muscle biopsy. A thin, flexible tube called a catheter inserted into a blood vessel in the arm or groin. It is guided to one artery in the heart. Dye flows through the catheter to help the heart arteries show up more clearly on X-rays. A tiny sample of heart muscle tissue may be taken during this test. This is called a biopsy. The sample is sent to a lab to be checked for signs of myocarditis or infection. The virus is generally present in tissue and pericardial fluid samples only during the first 8 to 10 days of illness. Provider may perform endomyocardial biopsy if the other test results are unclear. Endomyocardial biopsy provides histologic confirmation of myocarditis. A biopsy is most diagnostic during the first 6 weeks of acute illness when lymphocytic infiltration and myocyte damage are present. Now we'll see the management and treatment. There is no curative treatment for myocarditis. However, the doctor may treat an underlying cause of the myocarditis if identified and may prescribe the medication based on the cardiac symptoms, type of myocarditis, and how severe it is. Sometimes mild myocarditis gets better on its own, but other times client might need medical treatment. Treatment objectives are targeted toward management of complications. Supportive care is the first line of treatment. Myocarditis treatment may include medicine, medical devices, and surgery. People with mild myocarditis may only need rest and medicines. If myocarditis is severe, medicines may be given through an IV to quickly improve the heart's ability to pump blood. Medicines may be used to remove extra fluid from the body and reduce the strain on the heart. Angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers and beta adrenergic receptor blockers are used if heart is enlarged or to treat heart failure. ACE inhibitor or beta adrenergic blocker is given to strengthen the heart's ability to pump blood and to reduce its workload, thus improve left ventricular systolic dysfunction. But it should be used with caution because it may cause hypotension. ACE inhibitor or angiotensin receptor blockers are given to lower the blood pressure so the heart doesn't have to work hard, and it helps with remodeling of the heart muscle after myocarditis. Examples of ACE inhibitors are captopril, enalapril. Examples of ARBs are losartan, valsartan. Beta blockers are given to slow down the heart rate and lower the blood pressure. It improves arrhythmia and help with remodeling of the heart muscle. In severe cases, aggressive therapy may be necessary. Ionotropes such as dobutamine and dopamine is given. An ionotrope or ionotropic is a drug or any substance that alters the force or energy of muscular contractions. Diuretics are given to the patient to reduce fluid volume and preload. These can help decrease fluid buildup caused by a weakened heart. It helps decrease fluid congestion in the body, which can occur when the heart muscle weakens. Example is furosemide. Antidyarrhythmic drugs, usually amiodarone, is given to the patient. Digoxin therapy for heart failure and atrial fibrillation. Corticosteroids are given to the patient to calm down inflammation in the heart and body. Corticosteroids lower the activity of the body's immune system. Corticosteroids may be used to treat myocarditis caused by autoimmune disease such as lupus. These medicines may be used to treat some rare types of viral myocarditis such as giant cell myocarditis and eosinophilic myocarditis. If myocarditis is causing severe heart failure or irregular heartbeats, medicines may be given to reduce the risk of blood clots in the heart. Medicines such as colchicine, non-steroidal anti-inflammatory drugs, and aspirin are given to the patient to relieve pain and to reduce inflammation. Side effects of these medicines include abdominal pain, nausea, vomiting, and diarrhea. Immunoglobulin, other antibodies, or infection-fighting proteins are given to the patient through an IV. Intravenous immunoglobulin helps control the body's immune and inflammatory response. Myocarditis with an autoimmune basis is treated with immunosuppressive agents to reduce heart inflammation and damage. Sometimes another health condition such as lupus causes myocarditis. Treating this underlying condition may help reduce heart muscle inflammation. Antivirals are used together with the primary treatment. Antimicrobial therapy if causative bacteria are isolated. If the patient is not hypertensive, IV drugs such as nitroprusside and milrinol reduce afterload and improve cardiac output by decreasing systemic vascular resistance. Anticoagulation reduces the risk for clot formation from blood stasis in patients with a low ejection fraction. Stop taking certain medications if they are the cause of the myocarditis. General supportive measures include oxygen therapy, bed rest, and restricted activity to be provided. Strict bed rest helps to promote healing of the damaged myocardium. Some people with myocarditis take medicines for just a few months and then get better completely. Others may have long-term heart damage that needs lifelong medicines. It is important to have regular health checkups after myocarditis to check for possible complications. Recommend lifestyle changes which may involve a low-salt diet and fluid restriction. Extracorporeal membrane oxygenation may be used to help the heart to recover or while waiting for other treatments such as a heart transplant. An ECMO machine works like the lungs. It removes carbon dioxide and adds oxygen to the blood. If client has a severe heart failure, this device can send oxygen to the body. During ECMO, blood is removed from the body through tubes, passed through the machine, and then returned to the body. In severe cases, if myocarditis caused heart failure or arrhythmias, the healthcare provider will treat those conditions using procedures include pacemakers, intra-aortic balloon pump, implantable cardioverter defibrillators, or left ventricular assist devices. Ventricular assist device helps a weakened heart to pump blood. A VAD helps pump blood from the lower chambers of the heart to the rest of the body. It is the treatment for a weakened heart or heart failure. The device may be used to help the heart work while waiting for other treatments such as heart transplant. Next procedure is the intra-aortic balloon pump. These devices use a tiny balloon to help the heart pump more blood. These devices helps increase blood flow and reduces the strain on the heart. It is placed in main artery called the aorta. A doctor inserts a thin tube called a catheter into a blood vessel in the leg and guides it to the aorta. A balloon attached to the end of the catheter inflates and deflates as the heart beats and relaxes. Next device is implantable cardioverter defibrillator. A surgeon implants this device near the heart. When the heart beats irregularly, the device restores its normal rhythm by delivering a small shock. Next device is pacemaker. This device, similar to an ICD, helps regulate the heartbeat. If the heart function does not improve and continues to cause severe heart failure, client may be evaluated for a heart transplant. In very rare cases, severe heart damage might require a heart transplant. Many people recover completely with no complications or long-term damage. Others have chronic myocarditis. Either way, follow-up care can help keep track of any ongoing problems. It is also important to know that myocarditis can come back, although it is not common. Nursing management. Focus the interventions on improving cardiac output and managing the signs and symptoms of heart failure. Select nursing measures to decrease cardiac workload. These include placing the patient in a semi-fallow position, spacing activity and rest periods, and providing a quiet environment.